Hello everybody, welcome to our channel Medi-Concept. Today we will be discussing about few facts regarding abnormalities of adrenocortical secretion. Now before going to the main topic, just recapitulate few things about the hormones of adrenal cortex. We all know that hypothalamus secretes corticotropin releasing hormone that stimulates the corticotropes of the anterior pituitary to release adrenocorticotropic hormone or the ACTH that stimulates the adrenal cortex to secrete mineralocorticoids or mostly the aldosterone from the zona glomerulosa, glucocorticoids or the cortisol from the zona vesiculata, and sex steroids, that is the DHEA dihydroepiandrosterone and the androstenedione from the zona reticulata. Now coming to the main function of these hormones, we all know that mineralocorticoids or the aldosterone, it is important for the sodium, that is salt, and the water retention. So excess of mineralocorticoid or the aldosterone, it will cause increase in the blood pressure. Along with the reabsorption of sodium ion, it also helps in the excretion of the potassium ion from the body through urine. Now coming to the main function of the cortisol or the glucocorticoids. Now the glucocorticoids or the cortisol have a massive immunosuppressive effect. It decreases the eosinophil count. It is also an potent anti-inflammatory agent. Now the metabolic effect of cortisol, which are the most prominent features, that this cortisol increases the blood glucose level. It also catabolizes the protein, so it breaks down the protein, okay? And over the fat metabolism, it causes redistribution of fat from the peripheral parts of the body to the central part of the body, over the trunk and over the upper part of the body and over also the face. Over the bone, it also increases the osteoclastic activity. That means it causes the bone resorption. So if there is cortisol excess, it will cause osteoporosis, okay? Now the effect of sex steroid, that is adrenal sex steroid, it is negligible compared to the gonadal sex steroids, and physiologically it is responsible for the adrenarche, that means the development just before the onset of puberty. Next, it has this adrenal sex steroid, they have some musculizing effect, and this adrenal androgen are the source of estrogen, where the DHEA it is converted to the estrogen at the peripheral tissue by the action of the enzyme, the aromatase. Now, if you broadly categorize the abnormalities of adrenocortical secretion, you can divide it into two groups. First one, the hypoadrenalism, where the secretion of the adrenocortical hormones are decreased. You can also call that adrenal insufficiency. And the hyperadrenalism, where the secretion of the adrenocortical hormones are increased. This is also called the Cushing's syndrome. Now coming to the different cause of this hypoadrenalism or the adrenal insufficiency, it can be divided into two groups. First one is the primary and the second one is the secondary. The primary, the causes of this primary hypoadrenalism, where the cause lies itself in the adrenal gland. So this primary hypoadrenalism, it is also called the Addison's disease. Addison's disease. You can remember the different etiology of the Addison's disease by the mnemonic AD. See, it is AD. So A for the autoimmune destruction or the atrophy of the adrenal gland, where the autoantibodies are produced against the cells of the adrenal cortex. D for the disease, where the destruction of the adrenal gland occurs due to the metastasis of the carcinoma or the tuberculosis infection. And the next D, it is the damage of the adrenal gland by the trauma or hemorrhage. The secondary cause doesn't lies in the adrenal gland itself, but it is somewhere else. Like if there is impaired functioning of the pituitary gland, that will cause decrease in the ACTH production. So that decreased ACTH production will cause adrenal atrophy because of lack of stimulation of the adrenal gland by the ACTH. Now coming to the hyperadrenalism or the Cushing syndrome causes. The main two causes are the ACTH dependent causes, where the increased ACTH will hyperstimulate the gland to increase the production and the secretion of different adrenocortical hormones. And the second, it is the ACTH independent cause, where the negative feedback mechanism of different adrenocortical hormones to decrease the ACTH secretion, it is still persisting, but somehow the hormones, the adrenocortical hormones levels are raised. And the another cause, where the continuous and prolonged excess use of steroids, like we use in different chronic inflammatory diseases, there may be the features of the Cushing's syndrome. Next, coming to the cause of ACTH dependent cause. ACTH dependent causes, like in case of the pituitary adenoma, which is secreting excess amount of ACTH, that will excessively stimulate the gland to produce the more adrenocortical hormones. This is Cushing syndrome due to the pituitary adenoma. It is also called the Cushing disease. So Cushing disease, it is a part of the Cushing syndrome. Next, if the hypothalamus it is not functioning properly and it is producing excess amount of the corticotropin releasing hormone, then it will overstimulate the anterior pituitary to release more amount of ACTH. And the third important cause is the ectopic ACTH production, like in the lung or abdominal carcinoma, that carcinomatous cell may be producing excess amount of ACTH. Next group is the ACTH independent causes, like where the adenoma it is occurring at the adrenal cortex. So that adenomatous cells of the adrenal cortex, it will increase the cortisol production and secretion from the adrenal cortex. So that cortisol or that excess cortisol, it will now causes the feedback inhibition of the ACTH secretion from the anterior pituitary. So the ACTH level it will be lowered in cases of this ACTH independent causes. And the third, we have already discussed that prolonged and excess use of steroids may produce some kind of Cushing syndrome like features, like we use the chronic steroids in chronic inflammatory diseases. So this is the basic of the abnormalities of adrenocortical secretion. Now how can you differentiate between the different causes of this hyperadrenalism? Now we use a test which is known as the dexamethasone suppression test. It may be of two varieties, where we can use a low dose dexamethasone or we can use high dose dexamethasone. In primary or ACTH independent hyperadrenalism, like what happens in adenoma of adrenal cortex, the cortisol level it will be high, but that increased cortisol it will now cause feedback inhibition of the anterior pituitary to decrease the ACTH secretion. So cortisol level will be high, but the ACTH level will be low. In secondary hyperadrenalism, which are ACTH dependent, we can divide it into two groups. Either the dysfunction of the hypothalamo-pituitary axis, or there is excess ACTH production. In both of the situation, the cortisol level it will be high and ACTH level will be high, but the source of ACTH in case of the pituitary adenoma, it is the ACTH producing cell from the pituitary adenoma, or hypothalamic dysfunction, where the excess CRH will hyperstimulate the anterior pituitary to increase the level of ACTH. So just by looking at the blood parameters of cortisol and ACTH, if the cortisol level it is high and ACTH level it is low, we can tell that this Cushing syndrome may be due to the adenoma of adrenal cortex. But if the level it is high, that means cortisol and the ACTH both level high, then we have to differentiate it by giving the dexamethasone. Dexamethasone, it is a synthetic cortisol. So when high dose of dexamethasone it is given, or it will cause inhibition of the hypothalamo pituitary axis to decrease the ACTH release. But in case of the ectopic ACTH production, like from the lung carcinomatous cells or the carcinoma of the abdominal organs, the ACTH level still it will be high, because there is no scope of feedback inhibition in these carcinomatous cells, which is present in the hypothalamo pituitary axis. Okay, so by dexamethasone suppression test we can differentiate the primary and the secondary hyperadrenalism